Hi everyone, welcome back to another episode of Psych Talk. Today I will be talking about Pica and Rumination Disorder, two rare eating disorders listed in the DSM-5. So, Pica is characterized by the consumption of non-food and non-nutritive substances such as chalk, hair, paint, soil. It's common in young children, pregnant women, and individuals with neurodevelopmental disorders. And this behavior obviously can lead to severe health risks, such as lead poisoning or intestinal blockages, especially if left unaddressed. And the diagnostic criteria in the DSM um, include A, persistent eating of non-nutritive, non-food substances over a period of at least 1 month. B, the eating of non-nutritive, non-food substances is inappropriate to the developmental level of the individual. C, the eating behavior is not part of a culturally supported or socially normative practice. D, if the eating behavior occurs in the context of another mental disorder, example, intellectual developmental disorder, autism spectrum disorder, schizophrenia, or medical condition, including pregnancy, it is sufficiently severe to warrant additional clinical attention. And some treatment strategies for Pica often involve behavioral management, where caregivers learn techniques like behavior charts to encourage safe eating. In some cases, nutritional supplements like iron can reduce symptoms. And with proper intervention, Pica symptoms may decrease within a few months, but it can persist, especially for those with intellectual disabilities. And why does Pica develop? Well, there is no single known cause, but there are several factors that can contribute to its development, such as nutritional deficiency. So, iron or zinc deficiencies are common triggers for Pica, and in some cases, the body may crave known food items in response to a lack of essential nutrients. Um, Obviously, these items do not address the deficiency, and developmental disorders also can be part of the development of Pica, such as autism spectrum disorder or other neurodevelopmental conditions where the behavior may serve as a form of self-stimulation or be linked to impulse control issues. It can also develop from trauma or stress, and Pica can become like a coping mechanism for dealing with that trauma, stress, or neglect. And it can be a self-soothing behavior in a stressful environment, especially when other comforts are absent. And sometimes pregnancy can trigger Pica as well. Some pregnant women just may develop specific cravings for non-food items, possibly due to hormonal changes or heightened nutrient demands, or also lack of certain nutrients. And also other mental health disorders like obsessive compulsive disorder or schizophrenia may include Pica as part of compulsive or psychotic behaviors. And in these cases, individuals may feel an overwhelming urge to consume specific substances. And some of the treatments, as I said before, can be behavioral reinforcement. So parents or caregivers are taught to use a reward system to encourage appropriate eating habits. For example, when a child chooses food over non-food items, they might earn a sticker or a token, which can later be traded for a reward like extra playtime or a favorite activity. And obviously, this approach helps reinforce the desired behavior by associating it with a positive outcome. We can do also environmental modifications. So in some cases, limiting access to non-food items can be beneficial. For example, if a child has a habit of eating chalk or paint, caregivers can remove these items from accessible areas. And this is especially important during the early stages of treatment to reduce immediate risks. We also have sensory substitution. Sometimes children with Pica are drawn to the textures or sensory properties of non-food items. So for example, if you think about sometimes we overeat certain type of foods not only because of the taste, but also the texture, the way it feels in our mouth. For example, there are some people who love eating peanut butter because of the dry and like chalky type of texture, whereas some other people hate that, the dry, chalky texture. And so therapists may work with caregivers to find safer alternatives that satisfy the sensory needs. For example, a child who craves chewing on food items might be given textured chew safe items as a substitute. And then we can provide nutritional supplementation. So if a deficiency is suspected, adding supplements like iron or zinc can reduce cravings for non-food items. And studies show improvement in some cases after taking a daily multivitamin or specific mineral supplements under a doctor's guidance, of course. Also, what is important, and I think I mentioned before, parent training and monitoring. So therapies often involve parents in the treatment process, and training them obviously helps with the kids' behavior because we teach them how to observe and monitor eating behaviors more closely. And if a child with Pica attempts to eat a non-food item, caregivers are instructed to gently redirect them to a safe activity or a snack, reinforcing that food items instead of reinforcing the non-food item. Okay, and now for rumination disorder. So rumination disorder involves repeated regurgitation and rechewing of food, typically starting in infants, but also seen in older individuals, particularly those with intellectual disabilities. And this behavior might function as a self-soothing activity, but can lead to malnutrition or even weight loss over time. Right now I'm going to read the diagnostic criteria from the DSM. So A, repeated regurgitation of food over a period of at least 1 month. Regurgitated food may be rechewed, re-swallowed, or spit out. B, the repeated regurgitation is not attributable to an associated gastrointestinal or other medical condition, example gastroesophageal reflux, pyloric stenosis. C, the eating disturbance does not occur exclusively during the course of anorexia nervosa, bulimia nervosa, binge eating disorder, or avoidant restrictive food intake disorder. D, if the symptoms occur in the context of another mental disorder, example intellectual development disorder, or another neurodevelopmental disorder, they are sufficiently severe to warrant additional clinical attention. And so what do we do in this case? So treatment for rumination disorder often involves a team approach, including medical professionals and behavioral therapists. Family therapy and cognitive behavior strategies can help address the stress or environmental factors that might trigger the disorder. And fortunately, with early detection, symptoms can often be managed effectively. And so one intervention we could use will be diaphragmatic breathing training. So individuals are taught to use deep diaphragmatic breathing to help reduce the urge to regurgitate. And so practicing deep breathing before and after meals can prevent the abdominal contractions associated with regurgitation. And the therapist may guide them in gradually learning this breathing pattern, making it easier to control the reflex to ruminate. We also have habit reversal therapy. So this behavioral approach teaches individuals to recognize the triggers and physical sensation that precede rumination. And once identified, they learn alternative responses like taking sips of water or engaging in an incompatible behavior, such as stalking, immediately after eating. And this breaks the cycle of regurgitation and swallowing. We use also positive reinforcement and reward systems, like in the case of Pica. We also do parental and caregiver training, as we do in Pica, and we use cognitive behavioral therapy. So for older children and adults, CBT can help address any underlying stress or anxiety that might contribute to rumination behaviors. And in cases where rumination is a response to stress, therapy can provide obviously healthier coping mechanism. And rumination disorder has obviously several factors that can contribute to its development. One factor can be self-soothing mechanism. So infants and young children, in infants and young children, rumination behavior can serve as a form of self-soothing or self-stimulation, especially if they lack other ways to comfort themselves. And the regurgitation can produce a pleasant feeling, like a reinforcing behavior. Developmental intellectual disabilities can also contribute to this disorder. So in these cases, the behavior may occur due to limited awareness of social norms around eating or difficulty with impulse control. Also, environmental stress and neglect. So children who experience high level of stress, inadequate stimulation, or neglect may develop rumination behaviors as a way of coping. And rumination can become a repetitive behavior that offers a sense of control or distraction from the environment. It can also happen because of behavioral reinforcement. So, for instance, if the child receives attention or comfort following an episode of like regurgitation, they may repeat the behavior to get similar responses, even if the initial intent wasn't to seek attention. And also gastrointestinal sensations. So some individuals might begin rumination after experiencing a gastrointestinal issue, like acid reflux or bloating, that creates sensations similar to regurgitation. And this can lead to habitual regurgitation as they become accustomed to the sensation. And least but not last, it can be also because of anxiety or other mental health conditions. So, for example, rumination disorder can also appear alongside anxiety, OCD, and in these cases, the repetitive behavior may serve as a way of managing these other mental health conditions. And that is it for this episode. Thank you for listening.